Welcome to our listeners to this activity, the problem with residual symptoms for patients with major depressive disorder, with some emphasis on insomnia. I'm Dr. Leslie Citrome, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York, and I'm joined by our faculty today, Dr. Joseph Goldberg, clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai, New York, and Dr. Paul Dolgramji, who's a family physician at Collegeville Family Practice, medical director of health service at Ursinus College in Collegeville, Pennsylvania. Welcome.
Thank you.
Thank you, Les.
So let's all start on the ground floor with a few definitions. We're going to talk about response, remission, but we need some definitions here. Non-response to treatment means little or no improvement, and we can actually measure this on a rating scale. And if the improvement is less than 25% from baseline, we generally think of that as non-response. Partial response is at least being 25 to 49% better on a rating scale. Now, that's pretty good. It's better than non-response, but it's not good enough, clearly. And there's still troublesome symptoms affecting function. But we can work with it and perhaps boost partial response to response and remission. Response is something that sometimes we get satisfied with, but it's really not good enough. It does mean a 50% improvement on a rating scale, but it's not remission. And treatment will probably be needed for residual symptoms. If we go further, we may reach remission, and symptoms are below a pre-specified threshold, so rating scale total score less than a certain amount. But patients in so-called remission may have residual symptoms and functional impairment. So we need to do even better than that. So we'll explore these and other concepts today. Now, let's go back to remission for a minute. We have several levels of remission that have been defined in the literature. Level 1 is remission, although with residual symptoms and some functional impairment. Level 2, remission without residual symptoms and some functional impairment. Now, how can that be? Well, when you ask people if they are in remission, sometimes they say no, even though their rating scale score says they are, and they describe some problems they have in their life. So we need to get to level 3, the ultimate goal of treatment. It's remission without residual symptoms and with good functional activity, so no functional impairment. And actually only 12 to 18% of people in remission achieve this level at the present time. Maybe it's because we don't focus on functioning as much as we should, or other reasons, and we'll explore some of them today. So, Paul, can you take us through some of the unmet needs with the traditional monoaminergic agents used to treat major depressive disorder?
Yeah, I definitely can. In fact, I'll even start by just pointing out what you said, which is that a lot of times patients are not getting to remission. That is one of the very most important challenges in MDD treatment. But there's a couple of other ones that I want to mention that our audience probably knows about, but let's enumerate them. First is the time to efficacy. We all know that when patients come in with MDD, depression, they've been suffering for quite a while, weeks, sometimes even months, sometimes even years, and they feel terrible. Their quality of life is down and they feel lousy. And we give them a medicine and we say, well, you may not even feel anything for another week or two, and you may not even reach maximum benefit for 2 months. So that's a definite challenge, and it's an unmet need. Second is the variable response and tolerability. Even when we prescribe a medicine, a lot of times we're just going by our hunch as to what might work best for a particular patient, maybe because of some of the experiences that we've had. There are some cheek swab tests that we can do to maybe guide us into what kind of metabolism that a patient has, but nonetheless, there's a variable response and tolerability. And some patients don't respond adequately. Others experience really unacceptable side effects. Next and third is adherence and switching. A lot of patients, they will come across a medication where they experience side effects and they don't really want to take the medication. They'll take it every other day, or sometimes they'll come to you and they'll say, I want to switch the medicine. And there you have another several weeks that you need for the medication to take effect. So that's another challenge. And finally, the need for adjunctive treatment. One of the things that we're going to talk about more and more is that one medicine often alone is not good enough to have our patients reach an adequate response, or particularly, of course, remission. So as a result of that, in many cases, we're going to tell our patients, look, your first medicine may not get you there. I might have to add another medicine. Now, speaking of the different medications, there are many antidepressants that we can choose from. Now, over the years, all these monoamine type medications, there have been close to 30 of them. And in a meta-analysis, all agents were significantly more effective than placebo for remission and response, but none of them really cornered the market. All of them pretty much have similar response and remission rates. So none of them actually have a particular advantage as far as remission and response. Some of them may have advantages as far as side effects go, because some of the common acute adverse effects include agitation, dizziness, GI symptoms, headache, and sleep disturbances. And we all know that maybe some medicine has more or less of this than the other one. And as far as the chronic adverse effects, they include sleep disturbances, weight gain, emotional blunting, cognitive impairment, sexual dysfunction, which is a major issue that patients bring up. Weight gain is another major issue they bring up. Some cardiovascular effects like hypertension and tachycardia. So these are some of the things that we need to keep in mind when we're prescribing medication for MDD, and we do. Now, as far as the efficacy, let's go back to that. We all know that the remission and response rates are not as good as what we'd like them to be, as you said, Les. And we have studies that go back from the 1980s to the 1990s to the 2000s, and a pooled analysis, and all of them are pretty much showing the same thing, which is the response rate is around 50%. What you can glean from that and maybe pass on to your patient is you can say to them in the best way that you know how to do it in your skills of discussion with patients, is that there's about a 50-50 chance that you will have a response from this medication. Again, response being more than 50% improvement in your symptoms. And this has really not improved over the many years. And in fact, in a pooled analysis, this is about the same. Now, the effect size, which is the standardized drug versus placebo difference for antidepressants in randomized clinical trials, is only around 0.3. So there's something which we look at, which is the unpublished and published effect size across interventions for MDD. And so in 2022, for example, an updated analysis that included newer antidepressants found an overall FDA-based effect size of 0.24 and found a journal-based effect size of 0.29. And just to talk about the effect size, it's a statistical measure that quantifies the magnitude of observed effect in a study, indicating how strong the relationship is between the variables, or how big the difference is between groups. So larger effect sizes suggest more meaningful and practical differences in relationships, while smaller effect sizes may suggest a more limited practical impact. And in the data that we have, they suggest a smaller effect size. And all this suggesting that it's not really impressive as to how things are going with antidepressants versus placebo. This suggests, therefore, that a lot of times when we have medications that we're treating our patients for MDD, we're probably going to have to consider an adjunctive medication. Now, going back to, again, the remission and response rates, we have the STAR-D trial, which came out around 19 years ago. We all know how it went, where patients were randomized to get citalopram versus placebo as step 1. Then step 2, if things didn't go so well, the citalopram group could either have a switch, or they could have an augmentation. Step 3 was also switch and augmentation. Step 4 was switch. And as this happened, we noticed that the response rates were about 50% or so. The remission rates were around 30% or so. And as the steps increased, the remission rates declined to step 4 being only around 13%. Where does this all take us? It all takes us to the fact that as all first and second line pharmacotherapies, they target monoamine neurotransmission. Some patients, therefore, may require other treatments to get them to remission and response. Maybe other methods other than the mechanism of action of the current medications that we have. SSRIs, therefore, they don't generally have a dose-response relationship for efficacy, but they certainly do have for adverse reactions. And finally, SNRIs, SSRIs plus, and atypical antidepressants are not vastly different than SSRIs for most patients with MDD. So it begs us to really look at the fact that these medications will probably get us to some response, most of the time won't get us to remission, and we need to do more to get our patients to remission, because there are perils in patients that suffer from a partial response. They have many more adverse outcome and its quality of life, as well as recrudescence into worsened states. There are many things that can go wrong when patients only have a partial response. So again, it mandates us to do as best as we can to get our patients to a remission situation.
Well, thank you, Paul, for that overview of where we're at. You know, it reminds me of what Albert Einstein says: if you repeat the same thing over and over again and expect a different result, you're insane. And that's basically what we do when we switch around the SSRIs, SNRIs, NDRI, and combinations thereof. We're doing the same thing, increasing the amount of monoamines at the synapse. Maybe we need to do something a bit different, modulate certain receptors, maybe monoaminergic receptors, and maybe other receptors, in order to get patients beyond partial response, get them to remission, and get them to remission without any functional impairment. That's really our goal. But we first have to know and understand residual symptoms better. And Joe, can you tell us more about residual symptoms?
Sure. So thank you for such sobering and clear thoughts, Paul. I want to just first echo two main things that you both said. First, as Les points out, to paraphrase, 80 to 90% of the patients we treat with major depression do not reach level 3 of remission. That is, that they're essentially symptom-free and functionally intact, 80 to 90%. And then secondly, the pharmacologies that we have to work with do better than placebo, but they're not even just imperfect. They work really well for a small minority of people, right? 30, 40% after you factor in the placebo response. And with every successive trial, the success rates get lower and lower. So by definition, realistically speaking, most people we treat with major depressive disorder are going to have some residual symptoms. Let's not be surprised when that happens, but let's also be mindful of what kinds of residual symptoms we're likely to see, since, as you were pointing out before, major depression is a very heterogeneous phenomenon. It involves mood, energy, cognition, sleep-wake cycle changes, impulse control, cognitive patterns. There's a whole range of things, and it's almost grandiose to think that one medicine is going to hit all those things. So statistically speaking, even if a patient reaches the definition of remission, let's say level 2, where their symptoms are below a certain threshold, nevertheless, close to half, maybe 40 to 50%, will still have some residual features left over. Very often those can be somatic symptoms, things around energy and sleep in particular. To be utterly free of residual symptoms is about maybe 1 in 5, 1 in 6 patients. So the scope of these problems is important. Now, ask patients, what do you perceive as left over after you've been treated? Even if you've been declared a responder, 50% better than when you started out, or a remitter, your symptoms are not 0, but they're low enough to be considered close enough to being a state of wellness. Patients will identify things like weight gain, sleep disturbances, problems with mood, trouble with concentration, and energy. If you ask the clinician, the first things they'll point to are sleep problems, somatic symptoms, anxiety, low mood, guilt feeling. So there's convergence here. We're not talking about very different kinds of target symptoms that are left over, but we do want to be aware of the ways in which what we expect to see left over may very well inform what we want to do next. There have been a few studies that have tried to look in a more granular way at what kinds of residual symptoms are left over, and a number of these all point to somatic symptoms: sleep changes, sleep disturbances, fatigue, energy, poor concentration, as leading the list when one rigorously and systematically evaluates what kinds of symptoms are left over. So this is very interesting, because if you think about depression, especially if you're thinking about differential therapeutics, you could talk about the extent to which the cognitive symptoms of depression might be residual. That is, low self-worth, low self-esteem, cognitive distortions about my efficacy in the world and my expectations, things that you might even think are particularly valuable substrates for psychotherapy. But then if we think about the physical aspects, lethargy, trouble sleeping, being awake and alert, the ability to bring to bear your attentional focus and your executive functioning in order to be able to do the work in a cognitive therapy really has its prerequisite the capacity to have enough energy and attention and focus to be able to move toward addressing the residual cognitive features. So I might even think of a hierarchy of the somatic, sleep, energy, and attentional processing symptoms as kind of prerequisites before we can even get into some of the more purely cognitive ideational aspects of depression.
You know, Joe, I started off by saying we'll talk a bit about sleep, and so maybe this is a good time to do that. Taken together, the scientific literature tells us that sleep is a critical marker or indicator of disease and recovery. We see it across many different diseases, and problems with sleep, comes to us no matter what kind of medicine we practice, no matter what our specialty is. Unfortunately, sleep quality and sleep duration are rarely assessed in the detail that they need to be. Sure, we'll ask patients, how's your sleep? But we don't go to the next step, not always. But I like to know about, do they have trouble falling asleep, staying asleep? Do they wake up early? Do they have nightmares? How restorative is their sleep? And how are they during the daytime? So we end up not really identifying all the sleep problems we should, and we're not treating optimally many of the disorders that are accompanied by sleep problems. It would really help us if we would regularly ask patients in more detail about sleep, be aware of the importance of sleep as not only a marker if someone is doing poorly, but also something fundamental to the disorder that we're treating. And I try to get at this in my routine assessments. Joe, what kind of sleep disturbances can we see in mood disorders in general and in MDD in particular? And how common is it as a residual symptom in MDD?
Common more than half the time, and any and all. Oversleeping, undersleeping, initial insomnia where it's hard to fall asleep, prolonged sleep latency, middle insomnia where you wake up during the night, and how long does it take you to fall back asleep, how many wakenings after sleep onset occur, and then often early morning wakening, a diurnal variation often goes with that. It's often useful to think about pinning down exactly what the patient's telling you when you ask them those types of questions, just as you described, Les, and then pairing it with things. So someone, for instance, who's saying, it's taking me an awfully long time to fall asleep, and then I wake up a lot during the night, you'd expect to see fatigue the next day. Someone who has atypical depression symptoms, hypersomnia, hyperphagia, low energy, we might also think about the extent to which those symptoms kind of form a constellation. And here I think what's critically important is to not deconstruct the symptom apart from the syndrome. So I can think of plenty of colleagues who will just say, well, you're having trouble sleeping. Let's give you a Z drug. Let's give you something that targets sleep. And to me, that'd be like taking somebody with pneumonia who has a persistent cough and going after the most effective antitussant without recognizing that this is a symptom of their syndrome. And so to go to the core really means, have we treated the ailment that's causing the problem, cough and pneumonia, sleep here. So we want to be very clear. Last but not least, two other things. I want to make sure that we're not seeing iatrogenic medication-induced sleep problems. So if someone's taking a particularly alerting medicine or a stimulant or something that's more adrenergic or something late in the day, is that causing them secondary sleep problems? People with mood disorders, both unipolar and bipolar, sometimes have high comorbidity rates of alcohol or substance use disorders. We'd hate to miss things like withdrawal states that occur during the night. People with bipolar disorder, a third can have sleep apnea. So we just want to be very thorough on the front end of assessment to assure that, is a sleep problem a residual feature of their depression? Is it an iatrogenic side effect of a medication? Is it a withdrawal phenomenon? Or could they have a freestanding independent sleep disorder? This to me is really the crux of what the clinician assessor is doing.
Well, thanks, Joe, for that overview. You know, we can have a patient who we're treating for MDD rule out problems with sleep apnea, rule out substance misuse, rule out iatrogenic causes of their sleep problem. And yet, despite the treatment with an antidepressant that otherwise has addressed their mood and potentially address also other somatic symptoms, it doesn't help with the sleep enough. And what do we do in addition to the antidepressant? Paul, we've talked a lot in the past about just Z drugs and DORAs, and there's now a SORA. So explain to our listeners what this is all about.
Yeah, sure. A lot of our patients with the depression will have insomnia, and typically it's middle of the night insomnia. And there are studies that show that if you treat somebody with MDD with an antidepressant and add an insomnia medicine at the same time, their remission and response rates are better. So to me, that says that that insomnia treatment should be part and parcel of our treatment of depression. So what I'll typically do is if a patient does have insomnia, I will give them a medication. Typically, I'll go to a Z drug, like S-zopiclone, for example, is a very good one that came out with clinical trials suggesting its benefit. Now, there are some antidepressants like trazodone off-label is used for depression with insomnia, but again, that's off-label. The DORAs, the dual orexin receptor antagonists, they're good for insomnia treatment. They don't have any data in depression yet that I know of. So I think that it's a good idea to treat somebody with major depressive disorder who also has insomnia to do something for their insomnia at the same time. And typically you won't have to do it that long, because as they develop a response to their depression and even go into remission, the insomnia goes away. So I'll typically tell them, use this medicine for about a month or two. After that, you probably won't need it. And in fact, oftentimes they stop the medicine themselves. So I think it's really important to treat the insomnia at the same time that you're treating the major depressive disorder with your medication.
Yeah, that's good advice. I don't shy away from using adjunctive sleep aids. I'm particularly fond of the dual orexin receptor antagonist for a number of reasons. I think we'll have an opportunity to discuss that in another program. But let's move on. Joe, just summarize for us the consequences of residual symptoms.
Well, imagine if you had a virus on your hard drive and you took it into a computer repair shop and they said to you, well, we removed half the viruses, off you go. Or oncology, we removed a lot of the tumor, but not all of it. So probably the biggest concern and consequence is it grows back and it keeps on giving. So very big risk factor for residual symptoms to blossom into full-blown relapses. In addition to that, even before that happens, impaired quality of life, higher morbidity, more functional impairment, less duration of wellness time overall, and also just the more symptoms persist, the more they start to hint at almost the new normal. You hate when patients start to sort of just take for granted, I guess I'm not going to be able to work. I guess I'm not going to be able to take care of my family. I guess I'm going to have to sort of resign myself and just take this as for granted. So I think we always want to try to maintain hope with a sense of recognizing and doing our best to point out that if there are residual symptoms, we want to stave off the potential for relapse, and at the very least, not do a victory lap when we don't have a right to do a victory lap yet.
Absolutely. So far we've talked about what residual symptoms are and what sort of factors go into the treatment, and what are the consequences if we don't address it. I think it's really important to have a tool that helps us identify them. So, Paul, in the remainder of the time that we have, let's go over, and probably this is a review for many of our listeners, how do we screen and monitor for residual symptoms of depression?
Yeah, one of the tools that we use, at least in primary care all the time, is the Patient Health Questionnaire 9, PHQ-9, which has 9 questions that we can have either done by a medical assistant. The patient can do it themselves. It takes about 2 or 3 minutes to do. And these are questions where we ask our patients, over the last 2 weeks, how often have you been bothered by any of the following? And it's all the DSM-9 driven statements: little interest or pleasure, feeling down, trouble falling or staying asleep, feeling tired, poor appetite, feeling bad about yourself, trouble concentrating, moving or speaking too slowly, and thoughts of death or dying, that sort of stuff. And they give themselves a 0 if it's not at all, 1 if it's several days, again in the last 2 weeks, a 2 more than half the days, and 3 nearly every day. And then we score this. So a 1 to 4 is minimal depression, 5 to 9 is mild depression, and 10 to 14 is moderate depression, 15 to 19 is moderately severe depression, and 20 to 27 is severe depression. So this is a nice way of gauging how well or how poorly somebody's doing as far as MDD. Plus, also when we follow them, we can do PHQ-9s. And in my practice, we screen for depression on all adult well visits when they come in. And when they have any kind of mood-related issues in their diagnosis, my medical assistant will administer a PHQ-9, giving me a numerical value on how they're doing in this state of depression. And by the way, I didn't mention that there's also a part that says if you checked off any problems, how difficult have these problems made it for you to, in your work, taking care of things or getting along with other people. So a very important tool in assessing and reassessing our patients with MDD.
Absolutely. I don't know what I would do without the PHQ-9, and I think we should call it the PHQ-10 because that 10th question about function is really essential. But there's a lot more granularity that we can seek out here. In a 2015 article by Dr. John Zajecka outlined a method for assessing and monitoring for residual symptoms. Joe, tell us a bit about this briefly as we're running short of time.
Measure, measure, measure. Use the PHQ-9, track it over time, be able to determine what's still symptomatic and what's not. It's a quantitative measure. Make sure you're not missing anything like bipolar disorder. Use a screener like the rapid mood screener for that. Make sure there's no substance abuse or anything else that's confounding the picture. And then delve into what is it the patient themselves identifies as problematic. So don't use DSM language, just very, very simple terms. Tell me about how you're feeling, your sense of vitality, your energy level. What are the problems you yourself are noticing in terms of how you feel, what you're thinking, and also in terms of your functioning. Since patients themselves very often will talk about how well they're able to show up at work or how consistently they feel they're able to do the things they have to do to take care of themselves at home. Try to get a sense of time frames. When was the last time you were feeling well? Compared to your personal best, how is now different from your personal best? One might want to get collateral information. Someone who knows you well, are they nodding their head vigorously saying this is a fair appraisal? Or don't forget you're leaving something out, and really always compare to what one's personal best is as a baseline.
Yeah, that's a good overview. In the time remaining, I have some questions for both of you. And probably these are the same questions our listeners have. What medications would you favor for patients with, let's say, cognitive impairment or anhedonia or fatigue or sleep problems? They're different, aren't they? Joe?
I'll start. Well, they are different, but they can also be interrelated. So I guess firstly, we'd like to make sure we're eliminating any confounders. So I don't love benzodiazepines. I don't love anticholinergics. I don't love antihistaminergic drugs in that setting. I want to make sure alcohol or other contaminants are not in the picture. And if that's the case, if we're thinking about attention, focus, energy, motivation, drive, initiative, particularly if serotonergic drugs are not turning the corner, as we saw with the earlier data, some of the newer agents may have a little more value for things like attentional processing. Vortioxetine has some nice data in that regard. For anhedonia and motivation and drive, the combination of dextromethorphan with bupropion has been shown to have a pretty rapid benefit overall, as well as targeting anhedonia as a feature if one is using an adjunctive atypical antipsychotic, which we sometimes do. Sometimes those can also help with sleep benefits. We'd like to shy away from the antihistaminergic, anticholinergic ones if we can, and think about the ones that might be pro-dopaminergic in the prefrontal cortex. Maybe some of the partial agonists like brexpiprazole or aripiprazole might be actually helpful for some of the pro-attentional, pro-motivational features. So I think, as you say, don't do the same thing over and over again. And also keep an eye on the severity of symptoms overall, because if things are blossoming and getting worse, you may have to go to an even sort of higher breadth of spectrum intervention for a more severe depression that's brewing.
Well, thank you for that, Paul. In your experience, which depressive symptoms are the most difficult to bring into remission?
Yeah, interestingly, the most difficult ones are anhedonia. That is a really big one where a patient will say, yeah, I'm feeling less depressed. I don't feel sad. I'm not really motivated that much, or I'm not really getting enjoyment as much as I want to. That's a difficult one. So anhedonia is one of them. Or the other one could be a sleep problem. Even if we've addressed it, they might still be saying to me something like, well, I still am not getting as good a sleep as I would like, and I'm also tired during the day. Sometimes they'll even complain about cognitive problems where they'll say, like, for example, I'm the medical director of a college, and I do all the college students' psychiatry there. And they'll say to me, I'm just not performing as well as I'd like to. in class, and my memory and my cognitive abilities are not as good. So these can pose challenges, and sometimes it will make us think that a patient is not in remission, or maybe partial remission, and maybe then adding a medication is one of the things that you think about at that time, augmenting.
Well, thank you for that. Unfortunately, we're running out of time. I'd like to invite all our participants to claim their credit. Here is a QR code that you can use in the URL. Be sure to get credit for the time you spent in this activity. Joe and Paul, thank you for this great discussion. I hope we can do it again soon. And thank you, our viewers and listeners, for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.